Hello everybody. Today we are going to discuss about heart failure with preserved ejection fraction. Individuals with the heart failure typically have symptoms of breathing difficulty and fatigue leading to the limited activity and poor quality of life with or without more specific symptoms such as orthopnea and paroxysmal nocturnal dyspnea. The universal definition and societal guideline classify heart failure according to the left ventricular ejection fraction. So the heart failure is classified into three types. The heart failure with reduced ejection fraction. In this, ejection fraction will be less than or equal to 40%. Then heart failure with mildly reduced ejection fraction. In this, ejection fraction is between 41 to 49%. And heart failure with preserved ejection fraction. In this, ejection fraction will be more than 50%. So pathophysiology of heart failure with preserved ejection fraction is complex and heterogeneous, cumulatively expressing a range of pathological processes from inflammation, metabolic derangement, and dysfunctional mitochondrial energy production to large artery stiffness and LV remodeling. Conditions that contribute to the phenotypic presentation of heart failure with preserved ejection fraction include arterial hypertension, obesity, type 2 diabetes mellitus, CKD, pulmonary hypertension, atrial fibrillation, ischemic heart disease, valvular heart disease, and COPD. So all these are possible etiologies if we are seeing the patient with the heart failure with preserved ejection fraction. So, why heart failure with preserved ejection fraction is so important? Because the mortality in the individual with heart failure is markedly higher than the age-matched general population. Now, those who are hospitalized for heart failure have median 5-year mortality of approximately 75%, with similar rates for heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. And more than 80% of patients who are hospitalized for heart failure with preserved ejection fraction are re-hospitalized within 5 years, with about 40% of readmission being due to heart failure. Now about diagnosis. The establishing diagnosis of heart failure with preserved ejection fraction can be a challenging process that includes consideration of clinical, laboratory, and imaging parameters while excluding other potential causes of be considered as an potential diagnosis in individual with the dyspnea, exercise tolerance, or edema, and if cardiac cause appears likely, then lab and imaging test can confirm or exclude the diagnosis as well as categorize patient as having heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. So universal definition of heart failure defines heart failure with preserved ejection fraction as a clinical syndrome with current or prior symptom and or signs caused by structural and functional cardiac abnormality with ejection fraction of at least 50% corroborated by elevated natriuretic peptide level and objective evidence of pulmonary or systemic congestion. Measures of structural heart disease and diastolic dysfunction provide objective evidence supporting heart failure with preserved ejection fraction diagnosis. So, important role in the diagnosis of this heart failure is played by natriuretic peptide. So natriuretic peptide levels are considered to be elevated in ambulatory setting when serum natriuretic peptide levels are at least 125. And in hospitalized or decompensated setting, these levels should be at least 300 to call it as elevated. Now, please remember about natriuretic peptide level. These levels are low in patient with the high BMI. So if you see the obese patient and if you have diagnosed that patient with heart failure with preserved ejection fraction, and if the natriuretic peptides are low and if your clinical suspicion is high, then please go for echo. So we can also consider, as there is a evidence of congestion can also be obtained on chest X-ray, echocardiography, hemodynamic measurement. Sometimes exercise testing is required to demonstrate raised feeling pressure, either with echocardiography and right heart catheterization. So these are some scoring system which will help in diagnosis. So this is known as H2PF-EF score. H2 is heavy and hypertensive, that is body mass index of more than 30, and other H2 is hypertension. Then F is atrial fibrillation, which includes both paroxysmal and persistent. Then P is pulmonary hypertension, which is evident by Doppler echocardiographic estimate of pulmonary artery systolic pressure of more than 35 mmHg. Then E is elder, that is age more than 60 years. And F is feeling pressure, that is Doppler echocardiographic evidence of E by E prime of more than 9. Then there is HFA with preserved ejection consists of 4 steps. So first is P, that is pre-test assessment, which includes, in this, we should consider the symptoms and signs of heart failure patient. Then we should also consider their comorbidities, what are risk factors, what is ECG, echocardiography, and natriuretic peptides. Also, we should consider ergometry, 6-minute walking test, and cardiopulmonary exercise test. Then E is echocardiographic and natriuretic peptide score, which includes comprehensive echocardiography and BNP levels. Then the F1 is additional work, that is functional testing, which include diastolic stress test, exercise stress echocardiography, and invasive hemodynamic measure. Then final F is etiological workup, which include cardiac magnetic resonance, biopsy, PET scan, genetic testing. Then heart failure mimics are cardiac mimics are infiltrative cardiomyopathy, coronary artery disease, valvular disease, pericardial disease, and arrhythmia. Non-cardiac mimics are lung disease, anxiety, uh, depression, anemia, severe obesity, physical deconditioning, renal disease, cirrhosis, and chronic venous insufficiency. So these heart failure ejection with preserved ejection fraction mimics are typically identified or suspected based on thorough history and physical examination. Standard clinical investigation include biochemistry, full blood count, natriuretic peptide measurement, ECG, chest radiography, and echocardiography. Then advanced cardiac imaging with invasive and CT coronary angiography may be considered in selected patient or functional ischemia testing if coronary artery disease is suspected. Then cardiac magnetic resonance imaging, bone scintigraphy, and positive PET scan may be considered in patient with increased LV wall thickness, which is either unexplained or out of proportion to the voltages seen on electrocardiography in order to diagnose inflammatory and infiltrative cardiomyopathy. Now let's have a look on the trial. So first is STOPCAT trial, which enrolled the patient with ejection fraction of 45% or more. So the mineralocorticoid receptor antagonist, spironolactone, found to have reduced the incidence of first heart failure hospitalization, but did not reduce the composite primary endpoint. Now the next is Fine Arts Heart Failure Trial. Achieved 16% reduction in its primary composite endpoint of total worsening heart failure event and death from cardiovascular cause with non-steroidal MRA, that is Finrenone, compared with the placebo. Now the next is SGLT2 inhibitor. In this, there are Emperor trial and Deliver trial. So Emperor Preserve trial enrolled patient with heart failure and ejection fraction of more than 40%. And the treatment with empagliflozin led to 21% relative risk reduction in cardiovascular death or heart failure hospitalization compared with placebo. Deliver trial, which enrolled patients with heart failure and ejection fraction of more than 40%, and dapagliflozin led to 18% relative risk reduction in composite of worsening heart failure and cardiovascular death. So for both SGLT2, efficacy was similar in patients with or without type 2 diabetes mellitus. But the dapagliflozin improved heart failure symptom in patients with heart failure with ejection fraction of 45% or more in preserved heart failure trial, with similar finding reported in Emperor Preserved and Deliver trial. Now, the similarly recently STEP heart failure preserved ejection fraction trial have assessed the effect of treatment with glucagon-like peptide 1 receptor antagonist, that is semaglutide, in patient with heart failure and ejection fraction of 45% or more who had obesity and without type 2 diabetes mellitus. And there were reduction in reported heart failure related events. So these findings are also supported by select trial. Now we will see what are the phenotypes. So phenotype 1, it's seen in this, the patient will be young and few comorbid. Phenotype 2 will be patient will be older, high prevalence of heart failure, atrial fibrillation, and the high prevalence of the cardiorenal disease. Then phenotype 3 will be it's seen in intermediate age patient, high comorbidity burden, including type 2 diabetes mellitus and obesity. There will be the enhanced inflammatory signaling, metabolic derangement consistent with high comorbidity burden, and it may contribute to increased oxidative stress, release of pro-inflammatory cytokine, myocardial fibrosis, and increased pulmonary vascular resistance and right ventricular dysfunction. So let's have a look on the management. So whenever you will see the patient with heart failure with preserved ejection fraction, you can start SGLT2 inhibitor in the form of either dapagliflozin or empagliflozin. Then potential, so what is mechanism behind this, what is logic behind this starting this SGLT2 inhibitor? So how they are how they are providing cardioprotective effect is they help in improvement in hemodynamics, vascular function, erythropoiesis. It causes reduction in the tissue sodium, uric acid and epicardial fat. It will reduces the inflammation and sympathetic tone, increases in the ketone level, and it promotes the nutrient deprived signaling, while there is evolving evidence of beneficial effect on decongestion in acute setting. Loop diuretics are recommended for an individual with heart failure with preserved ejection fraction with symptom and signs of congestion. Patient with hypertension require treatment titrated to a 10 blood pressure target in accordance with the published guidelines. So if you see the patient with heart failure with preserved ejection fraction and high hypertension, it need to have at least 2 antihypertensive agents to control blood pressure. In all individuals with heart failure with preserved ejection fraction and atrial fibrillation, anticoagulation should be considered unless contraindicated. Recent randomized control trial reported that atrial fibrillation catheter ablation resulted in improved exercise hemodynamic, exercise capacity, and quality of life in selected patients with concomitant symptomatic paroxysmal and persistent atrial fibrillation and heart failure with preserved ejection fraction. So management of other comorbidity, including diabetes, obesity, obstructive sleep apnea, and depression is important to improve symptom and quality of life. So SGLT2 inhibitor is the first line agent for treatment of type 2 diabetes mellitus in patients with heart failure with preserved ejection fraction. Metformin and GLP are the another option. Regarding CKD, recent trial reported beneficial effect on cardiovascular and renal outcome with SGLT2 inhibitor on top of the background renin-angiotensin system inhibition. The use of mineralocorticoid receptor antagonist and renin-angiotensin system inhibitor, that is ARNI, may also be considered, especially in patients with borderline and mildly reduced ejection fraction to reduce hospitalization and improve symptoms. Additive benefits with combined use of SGLT2, MRA, and angiotensin receptor neprilysin inhibitor, extending up to LV ejection fraction of 65%, were suggested by indirect comparison of data from individual heart failure trial. The mineralocorticoid receptor antagonist Finrenon has also recently been reported to improve clinical outcome. Now, the patient with heart failure with preserved ejection fraction with obesity, that is BMI of more than 30, may additionally benefit from treatment with GLP-1 receptor antagonist, that is semaglutide, for body weight reduction and to improve heart failure with preserved ejection fraction related symptom and physical limitation. The effect of tirzepatide, that is the dual glucose dependent insulotropic and GLP-1 are being assessed in patients with heart failure with preserved ejection fraction and obesity in summit trial. Thank you guys.